today. Our first speaker, we're so delighted to have Dr. Sarah Oros, who is Assistant Professor of Psychiatry in the UK Departments of Psychiatry and Internal Medicine, and who is Program Director for the Combined Internal Medicine Psychiatry Residency. And her specialties include General Internal Medicine, Geriatrics, Primary Care, Psychiatry, and Women's Health. And she's going to be talking with us about pharmacological interventions for adults today. So thank you so much, Dr. Oros, for being with us, and take it away.
Thanks for having me. All right, well, let's get started. If you could go ahead and advance the slide. Excuse me. Today I'm going to discuss some of our suicide statistics and evidence-based strategies to help mitigate suicide, as that's something that I think primary care is increasingly seeing and being expected to manage. And then I'm going to review prevalence of mental illness and first-line treatments for depression in our time together. As far as suicide rates go, this is a graphic from 2020, our most recent data from the CDC. And on the left, we have females, and right on the males. And as you can see, males have a much higher suicide rate. It's about stable until you hit 75, and then the rate goes up. So that's really our population at most risk. All right, next slide, please. And then as far as ethnicity goes, just very quickly, most at risk are our American Indian population, followed by whites, and then Hispanic and Black, and then Asian. And then as far as suicide rates by state, the dark blue here in the United States is the worst on this heat map, and then white is lower rates. And as you can see here in Kentucky, we're not the worst, but we also have some ways to go. So we're at kind of 17 to 19 here. And then as far as screening goes, we know that 50% of patients who have gone on to die by suicide have presented to their primary care provider in the 1 month prior. So they have they've been touched by primary care. It's actually much higher than those presenting to a dedicated mental health provider. The Joint Commission does recommend asking about suicide in the outpatient setting. And the United States Preventative Services Task Force has insufficient evidence for screening for suicide, but does recommend depression screening. As I was just reviewing the guidelines this past week, the website does say that it's under review. So I don't know if they're getting ready to change their recommendation in asking about suicide, but it's something that's debated, and it's something here at UK we've incorporated in the outpatient setting. I do want to talk a little bit about asking about suicide. This was something I received a lot of training in my psychiatry residency, but on my internal medicine side, it was actually never talked about. So I'm going to go just through some of the questions I usually ask patients. It is important to establish rapport before diving, into direct questioning, so the person feels comfortable about talking and being open about some of their thoughts. I usually will ask about passive suicidal thoughts first. So have you had thoughts about not wanting to be alive, or have you felt like it did not matter if you woke up? And then if a patient's saying yes to these questions, asking more directly about active suicidal thoughts, such as, have you had thoughts about wanting to harm yourself? Have you had thoughts about wanting to kill yourself? And then have you gone so far as to come up with a plan? And if they have, please advance next slide. Talking about what they've thought about, have they made preparatory acts, and how long have these thoughts been going on? And in all of this, have they ever done anything to try to end their lives in the past? And if they have, what came of it? So, was it something where they took 2 Benadryl, went to sleep, and thought that was going to end their life? Or did they actually, sit with a gun and think about shooting themselves? And then what precipitated these thoughts? So is this something that, they just lost their job, maybe they're undergoing a divorce, and it's led them to this point? What's happened? And how has the patient previously dealt with some of these thoughts or ideations? And then asking about hopelessness, I think, is very important, as that's been a predictor of suicide. So does the patient feel hopeful that things will get better for themselves? And if they haven't, or if they don't, that kind of just should, maybe make you think about an intervention. Next slide, please. So what makes a difference? What have the studies shown? So actually, education of general practitioners in primary care has helped lower suicide rates, attempts, and ideation. There's actually mixed data out there, so some positive and some negative studies about screening for suicide risk. One of the studies was using the Columbia Suicide Screener, which is what we use here at UK. Was shown to be predictive of attempts in adolescents and young adults after a psychiatric crisis, if you will, ED. And then medications definitely have been shown to decrease suicidal ideation and suicidal behavior. So that's something that should be used as a first-line treatment. Next slide, please. Other things that have made a difference, psychotherapy, so cognitive behavioral therapy for everyone, and then specifically dialectical behavioral therapy and psychodynamic approaches in borderline personality disorder. Contact and outreach after a suicide attempt or suicidal ideation, kind of in a crisis situation. So after coming either to the ED or to a visit, that has made a difference in future attempts. And then means restriction has also been shown to be helpful in places that have restricted gun laws, that those places do have lower suicide rates. And in developing countries in which people use pesticides to commit suicide, in those countries that have restricted kind of the public access to pesticides, that definitely has decreased the suicide rate. So, you know, if a patient's coming in with thoughts, asking about firearms, and then talking to either the patient and or the family member about restricting it is very important. And that's something that you can do that will make a difference. And then moving on to talk about generally mental health. This is the past year prevalence in 2020. So about 21%, and then these are all comers. These aren't patients that present necessarily to a primary care office. And I think for those of us in primary care, you can probably attest to the fact that it's much higher than 21%, but these are, you know, kind of everyone. And more females than males, and then more so in our younger folks. Next slide, please. And then of the patients that do have mental health concerns or any mental illness, these are the patients that have received services in the past year in 2020. And so on the left here overall, 46%, so less than half, have received any type of mental health service. So, you know, there's still a fair number that we're not capturing, and more females than males, and less so for our younger folks that are older folks, and somewhat of a ethnicity skew. As far as depression treatment strategies, and I realize this is just a small kind of piece of the pie, first line are selective serotonin reuptake inhibitors. You don't have to use this as your first line, and certainly if there's an indication to use something else, you can. This is what the literature suggests. If a patient fails, if they have a side effect or the medication is not working, it is still recommended to try a different SSRI or an SNRI. So if your patient's dealing with chronic pain, it may be worth trying an SNRI. If a patient fails two SSRIs, you can switch to a different class. So if you haven't tried an SNRI yet, moving to that, a tricyclic antidepressant, or if they've had some benefit with the medication or at least no side effects, you can try adding on a medication to help boost the effect. And so one of those medications could be bupropion or mirtazapine. If a patient is anxious, you can try and augment with buspirone or a benzodiazepine. I typically don't just add these on kind of willy-nilly, but these are what the guidelines suggest you can do. At each point in treatment, you should be assessing psychosocial stressors. So how's everything going in the patient's life? Psychotherapy can be offered first if a patient prefers to try that and would like to hold off on taking medications. And then regular intervals of follow-up. So, you know, starting a patient on a medication and seeing them back in a year is probably not appropriate. Seeing them back in 4 to 6 weeks is usually kind of the typical interval of follow-up. And then, you know, if a patient's not getting better, what should you be thinking about? Asking about trauma is very important. And I find in a number of patients, that's kind of the underlying issue that's causing some of their symptoms. So asking about that. Ongoing substance use can certainly make treating mood a lot harder. So asking and screening patients for that. And then things that I think maybe more kind of getting into a psychiatry referral, personality disorder, and whether they're secondary behavior. These shouldn't necessarily be on the forefront, but just things that can be kept in the back of your mind. All right, and then reasons to refer to psychiatry, suicidal thoughts. And I started this, I realize again that it can be difficult to get patients in to see psychiatry. And so you may be left managing it. And hopefully some of what we've talked about today can make that a little bit easier. Potential mania, so if there's concern for a prior mania, or if you've sent your patient into mania via medication. Psychotic symptoms, it's just hallucinations, paranoia, treatment-resistant symptoms. So again, maybe you've cycled through 5 or 6 different medications and nothing's working. And then, if a patient's asking or they've tried a number of medications and you're thinking about maybe something more advanced, such as electroconvulsive treatment, TMS, ketamine, or esketamine. All right, thank you.
So we want to make sure that folks who are on the line know to use their chat to ask questions. So we don't have anything for you currently, Dr. Oros, in the chat, but I did want to follow up and just ask, from your perspective, because I know you deal with both internal medicine and psychiatry, so you have kind of a foot in both worlds. How do you see the management within primary care of individuals with behavioral health conditions? Is, I think we're trying to kind of help increase the confidence level for primary care practices to manage and to, what percentage of patients do you think can effectively be managed in a primary care setting from your perspective?
Yeah, I think a fair amount can. I think when you're getting into some of the bipolar or schizophrenia, that gets a little bit trickier. And even patients that have trauma that, haven't had therapy for it, that can also be tricky. But I think many of our patients can be managed in the outpatient setting with close follow-up. And I think we probably know there's probably not enough mental health providers in to see everyone that should be seen, needs to be seen. And so there's a lot that are left in the primary care setting. And I certainly have patients that I see in my primary care clinic, and I have colleagues that will try and refer patients to see psychiatry, but patients either don't feel comfortable or don't have the resources to get in to see someone. And they come back and they see primary care, even though that would be what everyone's most comfortable with. Yeah. So I don't know that I have a good statistic, but I think a lot of patients just end up in primary care. And I think if you have a good relationship with them and can get them to come back, that actually is a lot. And that's, I think, a lot of some of where therapeutic action lies.
Perfect. Yeah, great. Thank you so much. I really appreciate you providing a great overview of the evidence, and I'm sure that we will come back to you with some questions potentially during the panel section, and certainly folks may have additional questions they want to direct to you.